So we acknowledge WHO and UNHCR, who developed the Humanitarian Intervention Guide. My own personal connection with this has been right since the beginning, really. I was involved in one of the first uses of mhGAP HIG. We used that in Iraq at that time. So like last week, this webinar will be 90 minutes long. So please, if you could put your questions in the chat, and Agnes will signpost any questions. And then hopefully we'll have some time at the end as well. So I've put mhGAP training, but it's really a mhGAP orientation, because we're not going to cover mhGAP in 90 minutes. And when you do mhGAP HIG training normally, it lasts for a couple of days normally. The session is recorded, and please do feel free to translate into your own languages. So this is the Humanitarian Guide, and I put the link up so that you can all access this and use this. What we're going to do today is an orientation, a background, talk a little bit about it, but it's not going to substitute for a full training. And I thought we would probably emphasize a couple of the psychosocial treatments and things that I have learned and taken out of mhGAP, and that I use both in my own practice and when I'm working in the field. So I'm going to hand over to Vitalii now to give us some background on mhGAP in Ukraine. And for myself, that was my role in Ukraine, has been working with mhGAP in Ukraine and supervision. But Vitalii, you can give us some up-to-date.
Thank you, dear Peter. Just a small, at the beginning, just a small overview, small situational analysis. What was the situation with mental health in Ukraine before the 24th February, before the bombing of our city started. So according to the recent available data, at least 33% of population during lifetime could have at least one mental health related disorder. 10% at current time have a current disorder. And 1 year prevalence is near 18%. It's like a general situation. We have more data available, but I think, Peter, we will skip this part, these few slides with the data. Maybe it's just next. I will maybe next. Here's this slide is good. This is data about prevalence of PTSD, depression, and anxiety in internally displaced people. This is data from 2016. It's a displacement after the first Russian invasion and first displacement from the east region to the west and all over the world. We can see here actually a very huge prevalence of depression, of PTSD and anxiety, which is much higher than in general population. As well, situation with children also not like brilliant, PTSD symptoms, prevalence of PTSD symptoms are quite high. Again, it's a data from 2018. It's not data of after the retained during this last month. So we have to take this into account. What is the current situation? Nobody knows, but I can think that we can like double these numbers. So there is another part of situation. It's a service use. How many people actually use official psychiatric, psychological services, etc. So we have some data available. Those data show us that near the 4% of people actually use some kind of psychiatric services, outpatient, inpatient services in Ukraine. So here we coming to the, if we compare prevalence, prevalence, 1 year prevalence, and compare service use, we can have some kind of see some kind of imagine about gap in mental health service delivery. That's, so can you please next? So here you can see actually the gap and difference between the 18% and 3.8%. Actually, it's a huge gap. It consists near 6 million of people who do not receive timely support related to their mental health condition. So what were ideas what to do with this, and what kind of plans we had? So can you, Peter, do next slide? And next, please. And next, please. I think we will skip this part. So after the Revolution of Dignity, 2014, after the Russian invasion, the awareness about mental health raised, and this topic appeared in the public, and in 2017 we approved by government mental health concept note. It is focused on community-based care, integration of mental health into healthcare and social care. So since 2017 to 2021, we developed a mental health action plan, tried to approve it. Finally, we have this one. And during all of this time, with support of the Peter, with support of WHO, and you can see there are a lot of other our partners, MDM, MSF, Proliska, Academy of Family Medicine, World Bank, Ukraine, we established National mhGAP Coordination Group and started to make cases. We started to educate primary healthcare professionals in mental health using mhGAP protocol, mhGAP guideline, a general guideline, and HIG guideline. And in 2022 we had a second training of trainers in mhGAP, and we developed a plan to cover 50% of family doctors in Lugansk Oblast, which is now currently under siege. Everything destroyed there, actually. So, but we had this plan, and we moved toward those plans. We had a plan to change our legislation to allow family doctors actually officially deliver mental health services. We had a plan to make incentives for them, so they will not just to deliver services but receive sustainable payment from government for delivering mental health services for patients. So it was a plan. Actually, plan will continue. Here's the next slide. You can see pictures of the war. So I think here is Ores Suvalo, my dearest friend and partner, who's now working hard in Lviv region, working with IDPs and working with different transition points, supporting people. And actually he is also active trainer in mhGAP. In a few days he will deliver next mhGAP training for family doctors in Lviv region, so they will take care of people in of IDPs and other vulnerable population. Next slide, please. And after the war began, we started to promote mhGAP widely. So here you can see it's in Ukrainian, obviously, but you can see with support of NHS, National Health Services, and of Ukraine, at support of Ministry of Veterans, we provide absolutely open, short induction into mhGAP, picking different topic. It's just very small induction, like 30 minutes, but it widely open. It goes to all family doctors. They can attend and then become motivated to pass like full-time mhGAP training, which we will start to deliver soon. So I think here we are. We have a lot of plans. And I think we will manage. Thank you, Peter.
Thank you. Thank you, Vitalii. And that's really helpful to give the background to mhGAP in Ukraine, which has been such a big thing in Ukraine. And it's been really satisfying training for myself, training in Ukraine and doing supervision. And I know the program is really strong up until this conflict. So I'm now going to talk about mhGAP, HIG. And firstly, maybe just thinking again about what are some of the challenges in humanitarian emergencies. The urgency. When you're in an emergency, things have to happen quite fast. Scarce resources. You've got to be really imaginative and creative in how you allocate sources or use them. Limited training time, limited access to specialists, limited access to medication. These are all big problems in humanitarian emergencies. So mhGAP recognizes this in the HIG humanitarian version, and it is for people affected by disasters that need more help than just PFA. If you recall from last week, we said PFA is for people in distress, and if they go beyond a level where they can't look after themselves, they feel like harming themselves or harming others, then you come to mhGAP HIG. Because of the urgency and the circumstances, it's much shorter than the mhGAP implementation guide that some of you may be familiar with. So it's something that you need to use quite quickly and focused particularly on what's happening in the emergencies when there's less resources. And I'll just briefly, you may remember this pyramid from the psychological first aid talk, where psychological first aid fitted into different levels of the emergency pyramid, or the IASC pyramid, the Interagency Standing Committee. But here you can see that at the top of the pyramid, specialized services, mhGAP can absolutely be used here, although it's not specifically for psychiatrists, psychologists, but we know that mhGAP has a role for this, and especially in emergency situations. Focused, that's a primary care level, mhGAP is very appropriate, and probably less direct for these bottom two levels, which is basic services and strengthening community and family supports. But of course, in managing mental health, you do have to deal with all levels of this pyramid. So we know from, I think the 2019 WHO Lancet paper has some new figures for what we expect in humanitarian emergencies. 1 in 11 people have significant mental health disorder, and 20% have mental health problems. So this is a huge figure. So common problems are depression, anxiety, stress, grief, bedwetting, behavioral problems, and PTSD, substance abuse, gender-based violence, and relapse of pre-existing conditions, psychosis, depression, epilepsy. And this is absolutely what I've seen in my field work. And I don't know, Vitalii, this is something that you've seen as well in coming over from Ukraine so recently, that things that were there before, this is like a trigger. So I've been in field situations where we saw a big increase of the numbers of cases of psychosis, depression, and epilepsy was triggered by the stress and also by the lack of medication and the change in person's routine and life. These in the humanitarian mhGAP, the book describes a number of different conditions, and I'll take you through some of those, but we're not going to cover all of those. And Vitalii has mentioned some of the conditions that are common in Ukraine, even before this conflict. After conflict, you would see a lot of cases of stress, grief, depression is very common. Now, PTSD is common, but it has to be diagnosed correctly and not overdiagnosed, but it shouldn't be missed either. Psychosis very much is something that you see in humanitarian emergencies. Epilepsy, intellectual disability, substance abuse, suicide, and then this chapter at the end called Other Significant Mental Health Complaints. And I'll go through that in a moment. My experience of working in humanitarian sector was I saw acute stress, grief, depression, a lot of intellectual disability, substance abuse, and this chapter, Other Significant Mental Health Complaints. And how people present in humanitarian emergencies can be quite complex, and that might affect who comes to services. There's a lot of stigma. So that means, for example, something like psychosis may not present so much, or depression, these things that can tend to be hidden. Alcohol and drugs and suicide are also things that can be hidden. So the mhGAP HIG, it's a simple, practical tool that helps health facilities that are affected by emergencies in assessing mental, neurological, and substance use conditions. So this is a terminology of mhGAP. We talk about mental health conditions, which are things like depression, anxiety, psychosis. Neurological conditions is really things like dementia, substance use conditions, alcohol, other drugs. And in Ukraine, alcohol is a significant issue. And when people are under stress, people may use alcohol or other substances as a coping mechanism. These guidelines, the mhGAP Humanitarian Implementation Guide, is consistent with international guidelines of the global bodies who are expert in this area. And UNHCR has been a key part of this, these guidelines. So the Mental Health Gap Action Program, it began in 2008 as a program to address gaps in care for people with mental health problems. And this adaptation of the humanitarian came out in, I think, 2015, I think. Who is it for? Different to PFA. PFA last week is for everyone. Here, PFA, here mhGAP HIG is for doctors, nurses, midwives, clinical officers, psychiatrists, psychologists, but probably psychiatrists and psychologists would know this subject probably in more detail. So it's really for people who are non-specialists. And there's also a number of associated tools in mhGAP, which I've mentioned at the end of the presentation. The contents, advice for clinical managers comes first, and I'm not going to go into this, but this is kind of what you do if you're setting up a clinic in an emergency setting. Things like making sure you've got confidentiality, making sure you've got medicine supply. General principles of care is the core foundation of mhGAP, and we will talk about that in some depth. Then there are specific modules, and time allowing, we will go through as many as we can of those. At the end of mhGAP HIG, there's the glossary and the UNHCR Health Information System, which is a diagnostic coding system. Now, many places will use different types of coding system, but monitoring and evaluation is a key part of any program using mhGAP. You've got to have good data to plan your service. Now, I'm going to now go on to this core component, general principles of care. And there's 6 mentioned there. Agnes, there's a question.
Yes, there's been a bit of interest around, you mentioned seeing intellectual disability during a humanitarian crisis. And could you just elaborate a bit on that, and whether did you mean that the diagnoses become much more frequent, or rather the symptoms worsened?
Well, I can think of some examples. I've seen kids with autism, kids with intellectual disability. For example, they lose their homes, they lose family members, they may be homeless, they're in transit, they're moving around, they get stressed, the parents get stressed, the whole family is stressed. And then that can come out in people with intellectual disability who can't perhaps verbalize their distress, but it may come out in other ways, like behavioral problems or regression, in the same way that children are affected by humanitarian emergencies. In a lot of humanitarian emergencies I've been to, I've spent a lot of time dealing with bedwetting, which I always kind of see as a symptomatic of the stress that the community is under. I don't know, Vitalii, if you've got any comments on intellectual disability, or is there anything about what's happening now amongst the people leaving Ukraine now?
Yeah, it's a special case for Ukraine, especially in this situation, because for a lot of period of time we still have, since Soviet Union and after, and still we have this kind of huge facilities. It's not like psychiatric clinics, it's just places where people with intellectual disability and other severe conditions actually live without family support, without just under supervision of very small amount of stuff. So it's a huge problem as it is, but also now a lot of them were forced to move from east, from directly from the fire and from the bombing, move to the west region and fight some places, etc. So it's actually a huge problem, and I'm not sure whether they actually are counted during this replacement. So for sure some family doctors and other professionals, not just family doctors but other type of services can face a lot of such kind of people with such condition, and they definitely need to know what to do, how to recognize the state, and actually how to deal with it, etc.
And one of the principles of dealing with an emergency is you look out for the vulnerable people. So if I'm seeing someone in the field, I'm going to ask them, do you have any family members with disabilities? Because you want to know that those people who are more vulnerable are okay. You do see situations, and I have seen a situation, I can say, where this autistic young man lost his home, lost family members, and he was biting his arm, and there were chunks of flesh that had come out of his arm. And what we had to do, what his mother did, is she tied him up because she had nothing else she could do. What we did is we did principles of PFA and actual principles of general principles of care, and we got them a place to stay, which reduced some of the stress. Agnes, another question?
There was a comment saying that people with intellectual disabilities are more likely to have pre-existing epilepsy and or mental health conditions.
Absolutely. And epilepsy is a huge, certainly in my experience, it's been something that I've seen a lot of, because people didn't have access to their medicines and had relapse because of the stress they were under. So some of this is very much reflects back on PFA. So principles of good communication. So you can imagine in times of stress that communication needs to be even better. Principles of assessment, management, reducing stress and strengthening social support we'll talk about. Protection of human rights is a core part of mhGAP HIG. And principles of attention to overall well-being. So although this is like the introduction to mhGAP, whenever I'm doing a training, I spend a large part of the training covering this, because it's the basic principles, and you actually can use these principles in every module or condition of mhGAP. So communication, to start off with, I refer you back to PFA. This is all about PFA, having good communication, respecting the dignity of the person, having the right environment, so there's confidentiality, that the patient is involved and directs the care to an extent. So the traditional doctor-patient model, for example, and I guess how we were kind of trained, I was kind of trained in medical school, was the doctor knows best. We tell the patient what to do, and the patient accepts that without any questions or queries. Now that is something from the past. Now communication is about the patient and the health worker working in partnership for a plan. I know that some people say, well, the patient will say, you're the doctor or you're the health worker, you should know. To an extent, but you've got to get the person on board. And if they feel part of the plan, they will follow it. We know that. If people feel that they've been part of the plan, they feel more comfortable, we get better outcomes. So in HIG, listening is really, really important. And explaining. There should be no interaction between a health worker and the patient. I use the word patient. I know other people would use different words. That does not involve explaining what's happening, what's going to happen, asking, what do you think? Checking with the person that that's okay. Language, using language that the person understands. Being non-judgmental. So this can come up, for example, if you're dealing with someone who's Russian, or someone who you might find that you disagree with, people that there are prejudice against, LGBT, or anyone, you must be non-judgmental in using mhGAP HIG. Translators, and now this can be an issue because you need to have very good translators who can capture the essence of the communication. Assessment. Assessment covers physical health, mental health, social health. So physical, I think, is clear enough. Mental health, I think that's clear. Social, where are you going to live tonight? Where are you going to stay tonight? Do you have enough money to get by? Are you safe? These are kind of the social dimensions. And then to be alert for suicide always is a running theme in HIG. Always be prepared to ask about suicide, never to be embarrassed to ask about it. watch out for vulnerable groups. When I'm in an emergency setting, one of the things I'll do is I'll watch out and see, is there anyone in a wheelchair, for example, or anyone with an obvious disability? Watching out for children, women who might be at special risk, elders. So protection is making people safe. Sometimes you need specialist emergency care, and this happens like withdrawal states from alcohol, or someone who's self-harmed and they could die if they don't get emergency treatment. Vitalii.
Just to add small mentions that for if system is highly specialized, like in Ukraine, where doctors only do physical health and psychiatrists only do mental health, etc., etc. When it comes to education and training in mhGAP, it is one of the critical point when people somebody started to get mad, somebody started blowing off the mind. Why should I, as family doctor, to take care about social, mental, it's training about mental, okay, but why social cares? Why this social issue? Does it matter for me? There are social workers, let them do it. So it's take a lot of time actually to, not just to convince them, but actually to pick up some examples and to help them to understand why it's so important to have it all in one plate for one person.
And absolutely. And I have to apologize if there's any noise disturbance here, because it's a bit noisy where I am. But and working in emergencies, you do much more than I would as a psychiatrist in UK. You're looking much more, as Vitalii is saying, much more social. Even sometimes it can be spiritual. For people who are religious, you might, if they are religious, they might need to be reconnected, and they get a comfort from that. You're connecting families, you're using PFA principles, which, if you remember, look, listen, and linking people together for social support. So management is exactly the same thing. You're looking at management of physical health, mental health, social health, and that's social health might be knowing where people can go to get food, where they can go to get shelter, where they can get information about what's happening next, and manage suicide. If someone is unsafe, get specialist advice from the protection agencies. And for example, in the countries around Ukraine, there will be UNHCR will be there as one group that will be skilled in protection. And management, just to go again, make this message, management is participatory. It's about the health worker and the patient, and often their family, working together on a plan. It's not the doctor telling them what to do. It's the doctor explaining and then working at a joint plan. Explaining doesn't cost anything, very quick and easy to do, but really important. Involve family and carers, and follow-up is really important. Now, Agnes, you've got a question.
What would you advise for environments that are exceptionally busy, emergency room situations, or very busy clinics where people are, doctors and medical professionals are really stretched for time?
Yeah. You know, I don't think it's that different to a lot of countries in the world where clinics can have an enormous number of people. And it's about being focused, having good communication so that you can get a lot of things covered in time. Communication, for example, things you can do is you start off, you let the person talk, you get a lot of information. Don't interrupt, let them speak for a minute. You'll get a lot of information that way. You can, if you are managing the mental health conditions well, those people will get better, and that will reduce the burden on the clinics next time. It'll be that much easier. But in honesty, there's no great answer for that, because in emergency situations, services can be overwhelmed. But I think at the same time, people understand that, and people, it's stressful, it's frustrating, but there isn't really any other answer than that, just to try to work efficiently and help people understand the limitations you've got as well. So in management in mhGAP, they talk about basic psychosocial support. And this is very similar, if not identical, to psychological first aid that we talked about before. In each of the modules, there's a number of suggestions here, or not suggestions, or advice. Listen, which means don't pressurize the person to speak. As we mentioned last week, sometimes people want to talk, sometimes they don't. And just a quick example of that was when I was actually doing mhGAP HIG in Iraq. I was visiting one of the camps, IDP camps at the time, and this old elder came to me who could speak English, and he saw that I was English speaking, and he talked to me about how terrible it was in his life, because he was Yazidi, and what that was like to be Yazidi before the war, that there was stigma against this group. He then told me about all the terrible things he'd encountered, family members who were killed, things he'd seen. And I couldn't say anything because it was just such an overwhelming story. And I did speak to my colleagues afterwards and say, I really felt overwhelmed. I just didn't know what I was, mhGAP was kind of out the window. And they said to me, no, what you did was what you listened to him, and he wanted to speak to you. And that helped him a lot. And it really, when I reflected on it, it really was true. He wanted a witness to what he'd experienced. He wanted someone to acknowledge that. And I was there for that. And I think this will be something for Ukrainians right at this moment. They will want people to hear their story, to feel that injustice, their anger at the war, but there will be, and respect that. Ask needs of someone who's left Ukraine. Their needs will be food, shelter. Their needs will be practical things predominantly. They'll want to link to their families. Help them meet their needs. So that could be meeting their basic needs, emotional needs, physical needs. It might, in some cases, even be their spiritual needs. So one thing that I think might be important is that spiritual needs are addressed for people leaving Ukraine. As Vitalii said last week, for some people it's important, but not for many it's not. But to have it available, I think it's also like a cultural grounding to be able to go back to something that's familiar and comfortable. Protect people from further harm. Agnes?
What would your advice be on managing suicide risk in this situation that you've just described, when admission is not an option?
I will come to that. So we'll have quite a lot to cover, and we're not going to cover everything. It's not a training, it's an orientation, but we'll do our best to cover, and that's one of the topics we'll cover. Now, principles of reducing stress and strengthening social support. This is something that I think is absolutely core to managing in mhGAP. Assess social support. You find if someone is alone or have they got others with them. What are their current stresses? Accommodation, where are they going to move to next? What's happening to their family or parents back home? Positive coping methods. Now, this is like, I'm not going to be able to say for Vitalii, for example, or he for me, what are my coping methods? But you ask someone, what do you do that helps you cope with things? What helped you before? And that's, you can prompt them to think, yeah, this will be helpful. Problem solving, I'm not sure we'll get a chance to go through that in any depth today, but problem solving is a way of approaching people's stresses and maybe make them seem a little bit more manageable. Protection is always important, because if you feel safe, your stress is reduced. Breathing exercises and other relaxations, we'll try and cover that a bit. PFA we talked about last week. And every day in mhGAP HIG, we use PFA. In my work as a psychiatrist, I use PFA every day. Carer support, really, really important. Hand technique, I will come to now. Hand technique, I believe, comes from UNICEF originally, and this is a very nice, easy tool that fits with mhGAP management. And it's a tool of stress reduction, social mobilization, strengthening social support, behavioral activation, cognitive messages, and message of hope. And I'm just going to demonstrate that now with Vitalii. So Vitalii, you're going to be my patient. And I want you to show me your hand, like so. Okay, Vitalii, and in this case, you can imagine you're maybe like someone from Ukraine. Can you tell me, Vitalii, thinking of each finger, if each finger represents someone you can go to if you're having some stress or problems? A finger could also represent an organization or somewhere where you could get help. So Vitalii, can you tell me, can you go through your fingers with me?
Yes, so I don't know, but I will try. So I think first finger, it will be my wife, who I will ask her any support which I need. My second finger, I don't know, maybe my employer, maybe my project in which I work, and friends there to whom I can come and ask any support actually which I need. I think third finger, it could be actually my friends out of the work, and my next finger, maybe people from Facebook and other social media, social networks, where could I post some request for support and receive it.
So thanks, Vitalii. And every one of us has a hand, and we can all think about who we would go to if we were in difficulty. and we know it ourselves. If you have a problem, what do? You go to your family, your friends, you go somewhere where you can talk about your problem. And when you talk about your problem, you feel a bit better. And that's kind of, I think that would probably constitute what's called social mobilization, but in a very simple way. And you can actually use the hand physically, especially with children, or you could just put it in your mind and have a mental hand, just so that people know that you are never alone. There's always going to be someone with you. And that's really, really helpful to remember that. Now, next thing, can you get your hand up again, Vitalii? Okay, you've got these creases on your hand. These can represent things you do that make you feel better, activities.
Mm-hmm.
So
two things, yes, at least.
Yes, please.
Yeah. So I think first that I do my work. I do my work. It helped me to get better in these times. And second thing that I do, actually, I can be with my family. It's my great resource. So
spend time with your family. Great. And people will have their own individual ways of things that they do to make them feel better. People may like to have coffee with their friends. They may like to play with their children. One person told me that she likes flowers, which I didn't quite understand, but that's what makes her cope better. So everyone will have activities that make you feel better. And it really seems very simple, but if you get people to do those activities, remind them to do that, it makes them feel better. It reduces the stress and it strengthens themselves. Now, the last thing, if you can get your hand up again, is the two creases at the wrist. Mm-hmm. They represent something like a saying or something that you would say that makes you feel better. Have you got anything, Vitalii, you can think of?
Mm-hmm. Yes, I think first one is together we are stronger. It is always like some kind of support for me. And second, I think it's there is a song, the recent song of System of a Down music band, and there is there is a line like "make your stand." So it's like.
Thank you, Vitalii. So it's the fingers help you feel connected. The activities in the hand are things to do to make you feel better, which is behavioral activation. And this is like messages of hope, but you can adapt it. I know that from myself, I will use this every day in my clinical work, and I use it for myself. And things that I've done are things like messages might be like, you're never alone, things will get better. One thing that I've done myself is, if I've lost my keys or something, I'll have, every time I've lost my keys before I found them again. So very practical ways of reducing my stress. Agnes, you have a question.
There was some discussion in the comments around what do you tell people who are, who've lost so many, but I think you've just answered it by maybe reaching towards the smaller moments of happiness in these instances.
And I think when we're talking about grief, which we'll cover quite briefly, but it's such an important topic, and I'm always kind of surprised, or probably I shouldn't be surprised, but when I'm working in humanitarian emergencies, how much of it is about grief, funerals, and supporting people having their normal grieving and mourning rituals. So stress reduction breathing exercises, I might hold on that. Vitalii, do you want to mention any breathing exercise?
Yes, I can do it with everybody if
okay,
there is a time.
If it's quite quick.
Yes, we'll do it quick. I will not do a full version, just a brief to introduce. So usually I tell the patient such kind of things that when we are in stress, so sometimes we starting to breathe faster, and our stress is growing. So it is one of the good ways to reduce stress is to start to breathe slower and in full. So I ask them to, and I can ask you all to put your right or left hand on your stomach and another hand in your chest, and make a deep breath in, making your hand move. So you will like something like that. So the hand on your chest is not moving, just hand on your stomach. And make a deep breath in, keep your air there a bit, and make as much slow breath out as you can. And repeat 3, 4, 5 times. Each time you can do it slower and slower and slower, and you will see then in a 1 to 3 minutes your state will be more calmer, and you can actually then make some better decision. So we just like.
Thank you, Vitalii. And in mhGAP HIG, there is a description of breathing exercise. It's a full description. Another one that I use is the door technique, where I ask someone to imagine a door and to look at the top of the door, and when they move their eyes across the top of the door, to breathe in through their nose, and then to go down the side of the door, breathing out through their mouth, and to repeat that. And what I will do, one of the big problems in humanitarian emergencies is insomnia, people not sleeping. So I will tell someone, I want you to do this for 5 to 10 minutes at night before you go to sleep. I'm not going to prescribe any medicines. I need you to take this I need you to practice this and do this, and it really will help. So breathing exercises, a core part of management in HIG for every module. Problem solving, we're probably not going to get a chance to talk much about, but it's about making your problems in bite-size, easy to digest bits, so it's not overwhelming. So the common problems, things like where do I get food? Where do I get shelter? You can direct people to that. Now, human rights, very, very important core part of mhGAP HIG. People with mental health conditions are at higher risk of mental health violations, of human rights violations. They lose housing, they don't have access to their families, don't get access to health services. So here it's about treating people with respect and dignity, thinking about the social aspects and using PFA. It can't be underemphasized though, human rights. Attention to well-being is about dealing with all your basic needs. Physical health, vaccinations need to happen in emergencies, family planning, managing non-communicable diseases like diabetes and asthma still has to happen. And these are vulnerable people, people who have these conditions, elders. Other things that are part of principles of attention to overall well-being are child-friendly spaces. And in humanitarian settings, we talk a lot about this, the places where children can go to be safe. There's also girl-friendly spaces and women-friendly spaces. Now, the modules, just to go through the modules now, each module gives a general description, assessment questions, and then management plan. But we have actually covered a lot of this by talking about general principles of care. Now, the first module you'll see is acute stress. And we did talk a bit about stress symptoms last week. Remember, physical symptoms, mental symptoms, our emotional symptoms, thinking symptoms, our cognitive symptoms, and behavioral symptoms. Also in acute stress, very commonly problems of insomnia, very common problem. Bedwetting in children. And the bedwetting can lead to a big problem because what happens commonly is it stresses the mother who hits the child and makes it worse again. Hyperventilation, breathing excessively fast. Dissociative symptoms, which are things that you really do see in emergency settings. Things like pseudo seizures, which is a seizure that isn't epileptic, it's a stress response. Conversion disorders, I think we'd have to have another webinar just about that. Certainly it's something that we see in humanitarian settings, this is, for example, when someone has like a paralyzed arm, but there's no physical cause for this, or they go completely mute and there's no physical cause for this, and follow up. So in mhGAP HIG, there's the management is listen, ask them what their needs are, helping them with their needs, making them safe or protecting them. Every module, like acute stress, has psychoeducation as a component. So you're explaining the condition to the person. It's really, really, really important. Reducing stress and strengthening social support, I would summarize that as the hand technique. Culturally appropriate interventions. Now, maybe I'd turn to Vitalii. Is there anything that's culturally appropriate that helps people in Ukraine for acute stress?
Actually, the same as there is actually, I don't think there are some special kind of things, but usual as for everyone. So
yeah,
yes, sure, we should. What we should warn, we should warn people about not use alcohol, do not use different kind of psychoactive drugs, etc.,
yes,
to reduce stress. Because in Ukraine you can easily buy in every pharmacy like hidazepam. It is with prescription, but you can actually buy it, and you can buy other things, legal things, to substances to calm yourself.
And I can it depends on where you are, which culture it is, because some places might find things like music, dance, being creative, storytelling as a way that reduces stress. Resuming usual activities is important in acute stress. And if you can think of the hand, activities that people used to do, and in emergency situations, that's really, really difficult. But if my suggestion would be, let's go and play some football with the kids. Let's organize some dancing or something that people like to do. Let's organize some coffee or recreational activities, really as important in managing acute stress. When people are scared, and you've got to give people something that they can enjoy. Depression is a hugely important condition that we see in humanitarian emergencies. It's very common, and it can be difficult to distinguish from stress and grief. How you would do that, I'd refer you back to the modules, and you'll see that each module has a couple of assessment questions. So to go through those, but it can be very difficult because people can be depressed with stress, people can be depressed with grief. And here, mhGAP describes a number of classical symptoms of depression. And of course, those could be present in grief or stress. And your job is to really work out which is which. Managing depression with the things we've talked about in acute stress would not be wrong. Using the hand technique, problem solving, breathing exercises would not be wrong at all. But there are some specific treatments you would need for depression. So just to go back, these are the assessment questions, and each module will have these assessment questions. And it usually is, does the person have this condition, in this case, depression? And there's some pointers to what would constitute this condition. It's going to match to ICD-11. Are there any other possible explanations? So is there a physical health problem? Is there grief? Is it anxiety or PTSD? Is there a concurrent mental, neurological, and substance use problem? So is there substance abuse? Is there epilepsy? Agnes?
You both mentioned alcohol consumption, and there was a question around whether it could ever be an accepted form of social recreation within smaller limits.
Now, so I pass this back to Vitalii, knowing Ukrainian culture.
So guys who are listening to me, there are clear guideline and clear evidence that there are no safe dose of alcohol. So using alcohol for stress reduction is very bad and very unuseful strategy. This is my clear position, and sure, I do not articulate it so clearly to the patient. I use motivation interview, I use other approaches to move them back from this destructive behavior and to increase use of other useful strategies. So it's my clear position.
Thanks, Vitalii. And so I think it's between imaginative and thinking what are sort of find out what are the healthy coping mechanisms. So the assessment questions and then the management, yeah. Every module in management will be about education, explaining, but also doing activities and being aware of suicide all the time. Ukraine has a significant suicide rate anyway. So there's always got to be, you've always got to be aware of that. And alcohol can often be a mediator of increased suicidality intent. Address.
I just, sorry to interrupt, just related to alcohol. As it's not published yet, but there are data which we analyzed with our colleagues. So we saw that 70% of the suicide in Ukraine happened with after the use of alcohol.
Yeah,
so
it's
the data.
It doesn't surprise me because alcohol is a big issue, and how in conflict, suicide rates sometimes can go down as well, but you always got to be aware of suicide. Address current psychosocial stressors. This is about accommodation, money, and potentially domestic violence. Are they safe? Strengthen social supports. Make sure people are connected to people around them. That's the fingers. Stress management, the breathing exercises. Pharmacology has a role in depression. I'm not going to go into it in depth here, but one of the challenges in humanitarian emergencies is supply of medicine. And so you need to have an adequate supply, and that's going to be sustainable supply. And people are moving on quite fast, so you really have to bear that in mind. And that's the next question, is follow-up. Follow-up is a key part of any management in mhGAP and depression. One tip I've always used is whenever I'm with someone, I'll always take their telephone number so that I can make sure that I can follow them up wherever they might be. Then specific treatments, these are specific treatments that people need specific training to do, like problem solving. There's some tools and training to do that. Interpersonal therapy is very effective for depression. CBT is very effective. Behavioral activation as well. And now I move to PTSD. And whenever anyone thinks about emergencies, they think about PTSD. And Vitalii has mentioned the situation of PTSD in Ukraine. And as we know, the war has been going on since 2014. So PTSD, there are people who say it doesn't exist. And there are people who say there's nothing else but PTSD. So I think it's best to have a sort of a sensible middle line, that it exists, but you got to diagnose it carefully so that you don't label someone as having a condition, a mental health condition, whereas in fact they're just having normal suffering. So non-specific symptoms of PTSD, sleep problems, irritability, anxious or depressed mood, multiple physical problems with no clear physical cause. And then there's the specific symptoms, re-experiencing symptoms, avoidance behaviors, and then there's heightened sense of current threat. So if you jumped when I clapped, you might have that. But we all have these to an extent. It's about the level and about impairing daily functioning. For myself, I've seen some very unpleasant things in my life in humanitarian settings. I can remember them very clearly, but I can still eat my dinner and watch television and carry on with my life. But it's when you can't do that that you're looking at PTSD. And the management, well, there are specialist managements, and Vitalii I'm sure you will know about the specialist managements and could talk about that, like CBT with trauma focus, or the EMDR treatment. But you can always do the hand technique, reduce stress, breathing exercises, follow them up, assess for suicidality, do activities, and give message of hope. And one of the messages of hope is we know that most people with stress problems, and PTSD is in the family of stress problems, it goes away. It goes away for most people, whatever you do. Substance abuse, this is a big problem in Ukraine. A lot of alcohol and other substances in Ukraine. For people leaving Ukraine, I think it might be about the availability. Agnes, question.
Could you elaborate on avoidance behavior?
Okay, yes, absolutely. Avoidance behavior, an example I can give is someone who's in a car accident, and after that, they avoid going into cars. Or you're in a plane crash, or you avoid going into a plane. In the Ukrainian situation with conflict, Vitalii, I don't know if you can think of any examples of avoidance behaviors.
Yeah, so you can just for now, for a lot of people, it's almost impossible to hear these sirens when there is a warning about air attack, and they try to to hide some, do not hear it, or you you must saw recently this photo information from Bucha and from other villages near Kiev. So I think a lot of people cannot go there actually after it's now not occupied, but still.
And another example I can think of is someone who, this lady I met, and she was mugged and robbed by a man. So after that, she avoided being anywhere near men. So substance abuse, we're not going to go through substance abuse in any depth, but it is well written in mhGAP HIG. And one of the things that can happen, of course, when people are on the move, suddenly their supply of alcohol or substances drops, and that can be an emergency. So if someone develops alcohol withdrawal states like delirium tremens, that's a medical emergency. They could die. They stop their opiates, they may feel extremely uncomfortable. So this might require specialist care. So in management, you manage the harmful effects. Vitalii mentioned this motivational conversation where you try to get people to think about how they can stop drinking. And that's quite a, probably does need a bit of training to do that. You can look at strategies to stop or reduce substance, and that can be things like reducing the availability of alcohol or other substances. At the same time, all these other treatments are still valid. The hand technique, breathing exercises, problem solving, they're all valid here as well. And follow-up. People may not accept their problems, and you might have to follow up, and eventually they might come to you to seek help for this problem. Now, suicide, as we mentioned before, so suicide is a significant problem in Ukraine, and I think it'll be interesting is probably not the right word, but I think it would be interesting to know what happens with the suicide rate in this conflict, because sometimes in conflict, suicide rates can actually decrease, surprisingly. And we know that in humanitarian emergencies, there's an increase in mental disorders, distress, hopelessness, and this may lead to suicide or feelings of self-harm. And one of the most important messages is that always, always, always ask about suicide. Never be shy to ask about suicide. You are never going to suddenly make someone think, I'm going to kill myself. You won't put that idea in their mind. When we're doing education, for example, about depression, we will say to people, it's very, very common to have feelings of harming yourself. That's very common in depression. Vitalii.
I think that one of the idea why suicide rate during emergency decrease is because actually nobody counts. nobody make register. So it's I think you should be very careful with this idea, and always check for suicide, and always like actually expect worse than if better will come out. Okay, but I think we should actually always expect that suicide rate will grow up.
Yeah, I think that's a fair point. And then if anyone is very distressed, and also if someone is very, very quiet, check if there might be suicidal risk. And it always, always, always important to ask about this. You don't want to miss that. So one of the big clues, if someone has harmed themselves before and someone is very distressed or feeling hopeless, and the communication about suicide is very, very important, that you make sure people feel safe to tell you about this, that you have to balance confidentiality against being able to say, we have to make you safe, so we need to share that information. So when you manage suicide, medical management, if someone has cut themselves, have hung themselves, or taken some poison, you got to medical management, not to leave the person alone. Stop the means of self-harm. And this would be something I would really, people have to be very vigilant. Follow them up. And then the hand technique, would that be wrong to use? No, it would absolutely be right to use. Breathing exercises, absolutely. Problem solving, see what might be the issues there. But it's so important. Probably the number one message really, apart from medical management, is not to leave the person alone if you have any suspicion of self-harm, until you're clear that things are safe. And please do go back to the mhGAP to go through it in more depth, because it'll give more, we're just taking a little bit of a summary. Now, this chapter, my experience in humanitarian emergencies is that this chapter is a very, very common problem. This is a chapter called Other, or Other Significant Mental Health Complaints. This is physical health problems. It should say no physical cause, not physical cause. This is the psychosomatic problems. People having palpitations, choking feelings, shaking. Other things are anxiety or depression that doesn't fit the criteria for the chapter's depression or anxiety. And these conditions are significant if they impair daily functioning or the person is seeking help for them. And these are things that are common in Ukraine anyway, before the conflict. And I'm sure with the conflict, I have no doubt that these problems will increase. People will be complaining of physical symptoms, because it's hard to complain of mental health symptoms. People find it easier to, their stress comes out in their physical health. How do you manage this? Psychosocial support, psychoeducation activities. So would the hand technique be wrong here? No, absolutely correct here. So fingers for social mobilization, creases on the palm for behavioral activation, and messages of hope. Psychoeducation, explaining how your body works, that stress can cause physical symptoms. Reduce stress, breathing exercises, problem solving. Strengthen social supports is really the hand. These are difficult. This can be a difficult condition, but it really is important. The listening is very important. And the principles of PFA. So you're looking, you're listening and linking people. Now, adolescents may our children may behave in a different sort of way when they're under stress. They may have physical symptoms again, or there may be behavioral problems. And adolescents may have behavioral problems, or they may take substances, etc. And when you're spending time with adolescents, you have to give them more time and maybe spend a bit more time talking about activities or education or understanding their world. And adolescents will have all this will be disrupted. So the treatment will be trying to get some of those things back, activities, education back for them. Agnes, please.
Yes, we have quite a few questions. How do you distinguish between grieving people and people with depression, or people who are just worried about their relatives left behind and anxiety disorder? People in Eastern Europe there's common stigma in speaking out about depression and anxiety.
Yeah. Now, this is a good question about the stigma as well as speaking about anxiety, about mental health problems. And Vitalii can tell me if I'm wrong, but I found that in humanitarian emergencies, people may not talk about depression, psychosis, substance use, but people accept the concept of stress. People will understand that I'm under stress. And I often will use that language to talk to people, even if I'm talking about depression or acute stress or grief. I frame it as a stress thing so they can feel more comfortable to talk about it. Distinguishing between grief, acute stress, and depression, sometimes it can be impossible to work out, but if you go through the assessment questions, it may help you. Agnes.
What would you advise? So some people self-harm to cope with stress. How would you treat these patients?
Well, I would talk to them about positive coping methods. I would do the hand technique with them, absolutely, and say, what do you do that makes you feel better? And they may say, I cut myself. I will say to them, I accept that. Can you think of any other ways that you can cope? Are there anything else? And people who are despairing and grieving may not think easily of what they can do that makes them feel better. So you might have to say, well, think about the past. What did you do that you really enjoyed? And then you might get some clues as to what they could do now to make them feel better. Agnes, another question?
Yes, there's a question around the human rights aspect of treating refugees, and how this person worries that some refugees are forced into treatment, and if there's any that they might not be met with best practice, and he's worried about consent issues and what legal opportunities people have to defend themselves.
I'm not going to be able to answer all of that, but in emergency response, your emergency response needs to be professional, and health and protection kind of run side by side. In the UK, we'll talk about safeguarding, about keeping people safe, and some of the things you can make sure that you're operating good practice is that you have supervision, you have monitoring and evaluation, and that you're very vigilant against abuses of human rights. I think that's all I could really say about that. But I think it's something that in humanitarian response, it's such a big thing that it has to be built in, keep making people safe. Agnes, any other question?
No, just a helpful comment from Nick saying depression or anxiety are not terms that people recognize. It might be helpful to discuss it as sadness.
What you would use is, I would ask someone like Vitalii, what do people, how would people refer to mental health in Ukraine? And people may say sadness or other things, but as I was saying, my experience, certainly like in Syria, Iraq, Haiti, other places, South Sudan, is that people kind of get the concept of stress, and we all can say stress and not, it's acceptable, I think. Vitalii, what would you say?
Actually, for a lot of Ukrainians, depression and anxiety are like so very usual terms. It's like a lot of information, a lot of during the last years, especially during the last years, it was like a huge amount of messages. So depression now is even like not a disorder, but kind of like things that we used to mark our state, like, oh, I'm in depression. So it's actually
Ukraine is a sophisticated country, and there's been a lot of mental health work, and people are very sophisticated people. But when people are refugees, sometimes that goes out the window. But for myself, I know some people would argue and say you must use the correct terms. And I usually start by talking about stress, and then I will explain with psychoeducation the exact thing that we're talking about. And when people understand what's wrong with them, it helps as part of the healing. Now, we don't have time to talk to the other modules, but all the other modules are prisms to the humanitarian emergency. So you do see psychosis, protection becomes very important. We mentioned about intellectual disability earlier. So other tools I've just put in there that you can have a look at and look up. These are some other things that probably do need some extra training. Although I'm not sure about doing what matters at times of stress, might need extra training. I could be wrong, but certainly thinking healthy, problem solving, and group interpersonal therapy, you need some training to do those, but they're very helpful, effective, and I'm not sure if they're being used yet in the Ukrainian refugee situation, but Vitalii?
Yeah, so thinking healthy is already translated in Ukrainian, and we started to implement it before the war started. So I think we will come back to it soon. And problem solving is a few years ago already was adopted, and actually Medicine du Monde, I think, yes, they implemented it in Ukraine, so they have trainers and can actually do this scaling up. I think they will do soon.
Thank you, Vitalii. So any other questions, please? Agnes, is there any other questions or comments? Because I think we're just coming to the end of the time, and we've covered a lot, but one thing I will tell you, you go to your practice now and you use the hand technique. You either get your hand out or get their hand out, or do it in your mind with the person. Really, really useful. Breathing exercises, do that before you're giving out prescriptions for Zopiclone or Temazepam or whatever for insomnia and stress reduction. But you will be able to have a look at the mhGAP if you look it up, the link, and yeah, please do see how you can use it, and we hope that this will be something that will be helpful for the current disaster situation from Ukraine, as well as many other disaster situations around the world that are occurring right now. So I thank Vitalii. I thank Agnes, Ellen, Charlotte, and all of the participants here for attending today.
Thank you, Peter. Thank you also, team, that invited me, and I hope it will be useful.
So bye for now. Bye to everyone.